Welcome to CDM, our very last class. And I'm so sad I can't be with you, but this is the next best thing, is pretend you're with me. I just had a few things that I wanted to go over with you before I let you loose. And so you might just want to jot down some of the data, and then I have a few little demonstration things. It's just something to kind of remember that when people are on the thyroid, synthroid, that they should not take soy products. And I can't tell you why. It's just everything I read says it's some interference with the effectiveness of synthroid if people have very much soy. It may be that it takes a lot, and so it doesn't matter. And then I just wanted to emphasize so much to you the washing of hands, and to let your patients see you washing hands, and when you enter a room, go in and at least turn on the water and make them think you're washing them if you just got through washing them and you hate to wash them again. But patients have a lot of confidence if they think you're very conscientious about washing your hands. It came up in the IV lab that people were a little confused that piggyback and secondary were two different items, and they're not. A piggyback IV is the same thing as a secondary, and it goes into the main line above the pump. Now, if you have something joining below the pump, unless that's joining below the pump is free will, gravity, it probably is in a pump of its own. And it's really not called secondary. If it has a pump of its very own, it's just another main medicine or a main infusion. So piggyback and secondary go into the main line above the pump. Anything you add gravity, you would put it in below the pump. But if that second line needs to be pumped at a certain time and pace, then you would have it in another pump, and so you have two pumps, like down in the unit sometimes you did. Guaiac, G-U-I-A-C, I told you means hidden, and I mentioned that at the last class, and somebody came up and asked me if that could be for urine or for anything, and it can be for gastric, it can be for pleura, it can be for fecal. Guaiac means hidden, and it indicates hidden blood if they're looking for guaiac. Then I wanted to talk to you about the TED hose, and I mentioned them here and there, but I really wanted to go over what I want you to remember about the TED hose, and that's where I wasn't sure how good I did a job on that before the midterm, so I wanted to do it now. When you walk, and I may have already told you this, so just tune me out, but when you walk, your muscles are squeezing your veins and exercising your veins. And that's a great thing. That's why it's great to walk, because it's massaging your veins. When you are lying in bedridden, that isn't happening, and those veins become flaccid. They are supposed to be exercised all the time, and so they become flaccid, and that's why it's so easy for blood going through veins that aren't being active to start collecting and have a clot. So somebody scientifically discovered that we could put hose on and take them off, put them on and take them off. And if we do that once every 8 hours, that's enough. So your bedridden patient or your post-op patient just needs those TED hose taken off once every 8 hours. And of course, sometimes they don't get taken off till the next morning. You're in a bath. But you always take off TED hose to give a bath, because that's what you're doing, is massaging the veins. So bedridden, you can just take off the hose, wash their leg, put them back on, and you have done that massage. And as I said, for normal, healthy people, one of those times every 8 hours is enough. Now, if you are getting up and it's first day post-op and you put weight on the legs, that's doing a much better job than what the hose were doing. So if somebody stands weight bearing and sits down in a chair, then go on and wash their legs. Take the hose off and wash their legs. The big thing is don't put the hose back on until they're back in bed for at least 5, 10. Somebody told me the other day it really doesn't do any good unless it's about 15 to 30 minutes for the blood to get back up into the, out of pooling of the legs. I'm happy if you can just get legs elevated for 10 or 15, 5, 10, 15, just a little while. 5 minutes is okay for me. But keep watching, because I did hear that they are saying we need longer to have people on the bed before you put the hose back on. Because when you put the hose back on, if they've been sitting, it's squeezing pooled blood that has collected in the lower extremity, and then you put that tight elastic on it, and that's not so good for it. It's better if it's been drained. The pooling has been drained. Now, if they're walking, they don't even need the hose, and they really don't need the hose once they're weight bearing. So technically, as soon as they put their weight on their legs, they don't need the hose, because it's doing a better job than once every 8 hours doing this. However, people still wear them, and that's all right if they want to wear them, but I just want you to be and know when it's doing good and when it isn't doing good. So, the best case scenario is when a patient is bedridden, take them off, wash their legs, put them back on. If they're weight bearing and just kind of scooting over to a chair, then take them off, bathe their legs, and don't put them back on till they've been in bed 5, 15, an hour, whatever, in time for blood to get out of the legs from pooling, because they've been lower than the heart. If person is walking, they don't even need them, but a lot of patients have just been emphasized too that they need to wear those hose, so don't get in an argument. Just let them wear them. And I always say they're anti-embolotic when a patient's in bed. They are just support hose if the patient wants to keep them for a while and wear them walking around. Just call them support hose. In 2 weeks, they have served their purpose, and I call them socks. So after 2 weeks, they're really socks, and that isn't my idea. I talked to a woman at a medical supply house because she told me that TED hose are worthless after 2 weeks. And so I asked her, if we wash them and pat them dry with a towel, can I put them in the bathroom and the patient use them, have 2 pair and alternate? And she said, you can do that all you want to, but the elastic is gone for what it was supposed to have meant to do. So they're anti-embolotic when they're in bed, they're support hose if they're walking, they're socks after 2 weeks. Now what about the sequential compression? Somebody got an idea. Let's wrap this sequential compression sleeve around legs and then let them periodically be massaging. Great idea. A, they're hot. B, they're expensive. And there's no real scientific proof that it's any better than just at the foot of the bed asking the patient to push their feet up against your hands. Just push against me. There's just no scientific evidence. It's a great idea, but they're an expensive apparatus, and patients, a lot of times they're just in the floor. But the idea is massaging veins, and I wanted you to know that. And I've kind of beat that to death, but I do believe in them. And a lot of times when I'm with the student, we're putting the patient back to bed after we've kind of washed their legs or they've gone to the bathroom and we put their feet in water. Then we'll put them in bed and they'll say, you forgot to put the hose on. And I'll say, now let me tell you something. I want all that blood to get out of the legs, back up into the legs. And so I want them to lay like this about 10 or 15 minutes. If I don't come back in, so I'll pull out my worksheet, in 15 minutes, right, come back to this room. But if I tell them, if I don't come back, stick your head out and motion for me, and I'll come back, put them back on. They're very willing when they understand, but a lot of times they remind you, you didn't put the hose back on, or the sequentials. So I want you to teach a little there. Wanted to mention salt, and I don't think I have, maybe have, but if you don't salt anything, you'll probably get about a teaspoon of salt a day. And that's 2,000 milligrams or 2 grams sodium. And you know, you're told 2 grams sodium diet. Well, that's what it is. It's a teaspoon of salt, but we get it in our canned foods and our chips and other things. We get way more than that. And if you'll take the product and turn the label where you were looking for carbs for me, or servings and total carbs, look at sodium and know that our whole day's supply should be 2,000. And you know, 1 cup of Campbell's soup, I think, is just about that. So watch that, and when you teach your patients about sodium, just tell them never pick up. The idea is to never pick up a salt shaker if you're on a 2 gram sodium. Don't cook with it. Eat as little of it as you can, knowing that you're still getting a lot of salt. You get it in frozen foods and canned foods, and hardly anything is packaged that doesn't have a little salt for preserving. Now, while I'm on milligrams and grams and all, sometimes Tylenol and aspirin will be ordered as grains. And I just want to make sure you know that 60 milligrams is 1 grain. So, what's a Tylenol? 1 is 325 milligrams. And so, 60 into 325 is about 5. You have a little extra for overage. But a 5 grain Tylenol or 5 grain aspirin is 325. 10 grains is 650. And I just want you to know that 60 milligrams is 1 grain, and then 5 is 300, almost. It's 300, but they allow that 325 for a tablet. Just remember that a teaspoon's 5 milliliters, and I think that's good to always know anytime you're wondering, or you're wondering about measuring. Just keep that in mind. I mentioned last week, I want you to analyze, measure. You look at mucus or vomit or feces, and you don't have to package it up and put it in something. You can kind of look, would it fit, as I told you last week, a 1 milliliter syringe, a 3 milliliter syringe, a 30 milliliter medicine cup, a 240 coffee cup, a 120 juice cup, or a quart, which is 1,000 milliliters. I don't see this in your briefs, and I don't know why, and maybe it is in there. I just kind of thumbed through tonight to see if I could find it. But I want you to keep in mind D. Don't do dextrose and dilantin. In other words, if I had dextrose, D5W, flowing as my main line, and I had to give dilantin IV piggyback, they will clot like, or clabber, like they'll look like buttermilk. But sometimes things don't, sometimes they react and they don't, it's not visual. You don't see it turning white. But I just want you to always remember that don't do dextrose and dilantin, D, because it can catch you sometimes, and then you have to throw away all your apparatus and start all over. And a lot of times the pharmacy doesn't label dilantin, only give dilantin with normal saline. And then we have amphotericin B, and I want to see, I think that is in your medication